Hello, everyone, and welcome. Today, we're going to be covering a critical topic for anyone involved in the care of patients with spinal cord injuries: autonomic dysreflexia, or AD. This is a condition where quick identification and intervention are not just important, they can be life-saving. Our goal today is to ensure you feel confident in recognizing the signs, knowing the immediate actions to take, and understanding how to prevent it from happening. So, what exactly is autonomic dysreflexia? First and foremost, it is a medical emergency. It primarily occurs in patients with a spinal cord injury at or above the T6 level. In simple terms, AD is a massive, uncontrolled overreaction of the autonomic nervous system. It's triggered by a painful or irritating stimulus below the level of their injury. Because the pain signals can't reach the brain properly, the body's response becomes exaggerated, leading to a dangerous and rapid spike in blood pressure. Let's briefly walk through what's happening inside the body. It starts with a trigger, something uncomfortable below the injury level. This signal travels up the spinal cord, but gets blocked at the site of the lesion. The autonomic nervous system, however, still reacts to this signal. It triggers widespread vasoconstriction, a tightening of the blood vessels below the injury, which causes that sudden, severe rise in blood pressure. Your brain senses this dangerous hypertension and tries to compensate by slowing down the heart rate and dilating the blood vessels it can still control, those above the injury. But this response isn't enough to stop the crisis, which is why we see such a distinct set of symptoms. The triggers for AD are often things we manage in our daily care. We can remember the most common ones with the 3 Bs: bladder, bowel, and breakdown. First, the bladder. This is the most frequent culprit. A distended bladder from a blocked catheter, a full bladder in a patient on an intermittent cath program, or a UTI can all set off an AD episode. Next, the bowel. Fecal impaction or even significant gas can be enough of a stimulus. Finally, breakdown of the skin. This includes pressure ulcers, but it can also be caused by less obvious things like an ingrown toenail, a burn, or even just tight or restrictive clothing that's putting pressure on the skin. Anything that would normally cause pain or discomfort can be a trigger. The symptoms of AD are divided by the level of the injury. For the signs you'll see above the injury, a good way to remember it is high and red. The patient will often complain of a severe pounding headache. This is usually the first sign. Their blood pressure will be significantly elevated, typically 20 to 40 points systolic above their personal baseline. You'll see flushing of the face and neck, profuse sweating, and they may complain of nasal congestion or blurred vision. You'll also see a slow heart rate, or bradycardia, as the brain tries in vain to lower the blood pressure. In contrast, the symptoms below the level of injury are the opposite. A good mnemonic here is low and pale. The skin will be pale, cool to the touch, and there will be no sweating. You may also see goosebumps, a condition called piloerection. This clear division of symptoms is a hallmark of autonomic dysreflexia. When you suspect AD, you must act fast. There are 4 things to do immediately. First and most importantly, gravity helps pool blood the lower extremities when the patient is sitting up at a 90-degree angle, which can bring the blood pressure down slightly, protecting the brain. This is your absolute #1 priority. Next, loosen or remove any tight clothing, abdominal binders, or compression stockings. Begin monitoring vitals every 2 to 5 minutes. You need to track the BP closely to see if your interventions are working. While doing this, you must immediately begin searching for the cause. Your search for the cause should be quick and systematic. Start with the most likely trigger, the bladder. If the patient's Foley is kinked, has a blockage, or is full, this could be causing the problem. If there's no catheter, you may need to perform a bladder scan and catheterize the patient immediately if their bladder is full. Always use lidocaine jelly to numb the area and prevent more stimulation. If the bladder isn't the issue, move to the bowel. Is the patient due for a bowel program? Could they be impacted? A careful digital rectal exam may be necessary. If you still haven't found the cause, perform a full-body skin check. Remove their clothes and blankets and look for anything: pressure spots, irritations, anything at all that could be causing pain. If you've checked for and addressed the potential causes, but the patient's blood pressure remains high, it is time to escalate. Notify the physician or provider immediately. Be ready to administer rapid-acting antihypertensive medications as ordered. And most importantly, do not leave the patient alone. Continue your close monitoring until the crisis has resolved. While knowing how to react is critical, the best treatment for AD is always prevention. This is done through meticulous, proactive daily care. Maintain a strict bowel and bladder program to prevent impaction and distension. Ensure frequent repositioning and conduct regular, thorough skin checks. And finally, education is a powerful prevention tool. The more your patient and their family know, the better equipped they will be to help prevent triggers. I hope you enjoyed this video and learned a lot. If you have any questions, please comment them below. And don't forget to subscribe.